Hello, last time we have covered the abdomen area. Now we are starting the head and neck. So first about head and neck, we know these things. It is above the thorax, neck and head region or include many nerves, brains and organ. Many vessels include here. Many nerves, vessels, even most important organ, brain also include here. In head, brain include here. And it is the area above thorax. Hmm. So first, how we go? We we start from from superficial to deep. So first we starting the basically scalp, basically head region. So first we move from here. We start scalp. Basically the parts are first we move scalp, then face. We move superficial to deep. Superficial to deep. Then fascia, basically neck region basically glands are with thyroid gland. Then vessels and muscles, basically triangles we also study here. Then we go to the internal, basically nerves, from column, nerve columns, functional columns. Then, so basically, and then we move again further. So these are the starting point. We start from here. This is the scalp portion, basically head, hair region one, hair region portion, head, hairy skin of head. This is the scalp. So we move from here. Hmm. So this is our image. So this is scalp region. We study here. This is face, and this is neck region. And here, this is occipital region. This is the part of the skull, skull bone. This is the temporal region. This is the occipital region. All these. There are many views to view the skull. Then, so first we can write this region. This is temporal region near to temporal bone. Done. And here is occipital region. This is occipital region near to occipital bone. Then, so these are the some parts of the head and neck region. So here we starting the scalp. So in scalp there are five layers present from superficial to deep. There and their mnemonic is also scalp. Scalp. Okay, five layers. S C A L P. Scalp. So first layer, these are superficial to deep layers. So first layer is skin, and the second layer is C for connective tissue. Then another layer is this is epineurosis. Basically, it's the epineurosis of muscle tendon, flat tendon. Epineurosis. L is loose connective tissue. Loose areolar tissue. And P is perichondrium. Basically, the fibrous fleshy layer of the skull. Perichondrium. Pericranial. Pericranial. Chondrium, not cranial. This cranial. So these are the five layers of the scalp. Hmm. Here, this is the superficial, and this is deep. So order is like this: layer of superficial to deep. This is the pattern of the scalp layer. Then, so first we starting the skin. So it is a hairy layer, many hair follicles present, hairy layer, hair follicles, and some sebaceous gland also present. Sebaceous gland. Sebaceous gland. Glands also present. which form wax or wax lipids. Hmm. So it is it has epidermis and dermis layer as parts divided scales divided into epidermis and dermis. So this is histological part, layers of cell. Now in sometimes the sebaceous gland secrete many waxes and lipids, so there is a bump-like structure formed in the skin region. It is a clinical portion, clinical point. Due to excess secretion of sebaceous gland. Due to excess secretion of sebaceous gland, is swelling, bump-like swelling. Swelling form like this. Let's say this is the skull region. Hmm. So here is this type of swelling also formed. This is called cyst. So this bump-like swelling is called sebaceous cyst. Sebaceous cyst. Hmm. It is a swelling form like this. The next layer is connective tissue. Before connective tissue, we draw a diagram. Let's say this is the cranial bone. Done. So above cranial bone, just we know the deepest layer of the scalp, which is called pericranium, present like this. Above this, there is a layer called loose areolar tissue, which has fat like this. Many fat present here. It is a thick layer. Then above this, there is a muscle aponeurosis, and above aponeurosis, this layer is called connective tissue layer. The layer called connective tissue, like this. And the last, most superficial is skin. We can name this is skin, connective tissue, aponeurosis, process. Then loose areolar. Then this is pericranium, and this is cranium bone. This is cranium bone. So these are the layers. Remember, these layers present in two parts. There are five layers. So superficial three layers. These three layers are tightly adherent. These are tightly adherent. Adherent. By which layer? This connective tissue layer. It holds the skin and the epineuritic layer tightly. So first function of this layer, it holds the skin and aponeurotic layer tightly. These three layers remove by remove all simultaneously because they are tightly adherent. We cannot easily demarcate between them. Epineuritic layer. Then next, remember one important thing. Above, below cranium, there are some venous sinuses present, basically which collect the venous blood. There are venous sinuses present below cranium. Basically, they collect the venous blood, contain venous blood. Then these are called venous sinuses, and they are formed by layers of dura. So they are called dural venous sinuses. We study later. Now these are dural venous sinuses. These are dural venous sinuses. Hmm. They form some veins. These are called emissary veins from deep to superficial, like this, and they open in this layer here, like this. They also below the skin, like this. So these are called emissary veins. Emissary veins. So what is special about these veins? These veins are valveless. Emissary veins are valveless. So they can transport blood from in both directions, from deep to superficial and superficial to deep. So these veins mostly present in connective tissue layer. This connective tissue layer not is like thin. This is also thick layer. In raw, this is thick layer, and these veins present in this layer, connective tissue layer. Hmm? This is also thick layer, connective tissue. So what happens? These connective tissue tightly adherent the emissary veins. Clinical point. These connective tissue layer is tightly adherent, tightly attached to emissary veins. So what happens during any small injury? So what happens during any small injury? There is a blood collection. Blood collection can also here, and these veins. I mean, there is an injury in veins. Small injury in veins. Small injury in veins. So there is a blood bleeding occur. But now, normally we know the blood vessels retract, basically contract and close the bleeding spot. Normally, normally vessels retract. Retract means closes, come to close. They come to closer. Retract and close the spot. But here, लेकिन यहाँ पे क्या होगा? Now, due to connective tissue layer, these vessels outer layer is attached to the connective tissue layer. So these vessels opening lumen cannot retract. Let this it is like this. This is the vessel opening, and here is connective tissue attached. So this vessel lumen cannot retract to close the opening. This is connective tissue. This is vessel opening, vessel lumen. So these vessels cannot retract to close the opening like this. This vessel cannot retract, and bleeding occur continuous. Bleeding occur continuous, continuously. So what? So what we can do? We can apply pressure. So by applying pressure we can stop bleeding by putting pressure on that spot. Then, so these are two layers. The next layer is third layer is our aponeurosis. Aponeurosis. It is also called Galia aponeurotica or epicranial aponeurotica. Epicranial aponeurosis. 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 Done. So these are the three names. Galia aponeurotica, epicranial aponeurosis. Done. This is the third layer. But it is a aponeurosis of which muscle? It is a basically we know the aponeurosis is a muscle. So it is a muscle of occipitofrontalis muscle. It has two bellies. So how this muscle is arranged? So first again we draw. So this is a let's say skull. So there is a muscle present here from the above. This is the one belly of the muscle. This is called frontal belly, and from the behind from the superior nuchal line near to superior nuchal line. Again there is a muscle belly. These are two muscle bellies. These from the forehead and these from the superior nuchal line region. These two bellies are this not connect here. This actually this has not connection here. This is open like this. But this from this region, from forehead region, this layer is connected by aponeurosis. There is aponeurosis present between these two muscle bellies. This is aponeurosis of Galia aponeurotica, and this whole muscle is called occipitofrontalis muscle. Occipitofrontalis. It has two bellies, one and this one, and there is aponeurosis between these two bellies. It present behind to the occipital region, basically superior nuchal region, and in front it is open. In raw front it is open. So what happened is behind below this region, there is a loose areolar tissue layer present, and here emissary veins also present. So if emissary vein injury all occur here, so blood collect below this region. We can write point first aponeurotic layer. We have right origin, occipital belly and frontal belly. Occipital belly connected at superior nuchal line, and frontal belly is not connected to the bone. It is connected to the skin region. Frontal belly connected to the forehead skin region. overhead skin region. Hmm. So it contract and pull the skin. Basically, facial muscles are for facial expressions. It does not contract the skull region. It contract for the facial expression. And this epidermis. Below this layer, and this is adherent to the connective tissue. Adherent to connective tissue layer. Tissue layer. Now remember this point. This is open in the front region. This is a important point. This open in front region, and we write here open in frontal region. Front, open in front. ठीक है? The next layer is fourth layer is loose areolar tissue layer. Hmm. So first point it is present. Clinical point here we can add for clinical point we can add here clinical. If we cut the skull, basically we give the incision in the skull. So we give the incision like this, longitudinal, not plane. We give the incision in sagittal plane. During skull surgery, we give incision in sagittal plane. Otherwise, to prevent gap formation. Gap formation. This is formation. What is gap? We know this muscle. If this muscle contract, if this muscle is contract, so it pulls in this fashion. This muscle go in this point, this region, and this belly go in this region. So it contracts in this fashion. Basically, sagittal plane it contracts. Now, if we give the incision in coronal plane, so what happened? This muscle cannot be again joined and give this muscle cannot be joined completely, and there is a gap formation between this must basically, so there is wound formation here occur here because this muscle contract in sagittal plane. So if we cut the muscle in coronal plane during skull surgery, we give the incision in coronal plane, so there is a wound formation because when this muscle contracts, the wound again open. So wound again open and there is a gap. This wound is called gap. So gap formation occur and there's abnormality can be found. So to prevent this abnormality, we give incision in sagittal plane because this muscle contract in this manner. If we give the incision in this plane like this, if we give the incision in this plane, so this muscle divided into two parts, and This muscle divided into two parts, so this muscle cannot be again become normal, because there is a very less chances to become normal, because these muscle fibers cannot be again rejoined. But if we give the cut incision in longitudinal plane, so there is a gap, there is a just very small wound form, and after some time, because when muscle contracts, so there is no gap formation occur, because let's say this is muscle, this is muscle, this contract in this manner above and below. So if we give incision in this plane, so this muscle divided into two parts. This is coronal plane, coronal section. Then let's say this is the superior view of the skull. Muscle, this muscle. Hmm. So if we give so this muscle divided into two parts, and this muscle cannot be again region. But if we give the incision in this plane, so this is not harmful, not harmful, because when muscles contract, so this wound cannot again open. But if we give the incision in this plane, so when muscle contract, the wound again open, wound open. So that's how we give the incision. Now come to the fourth layer, loose areolar. It has fat present. Basically, the emissary veins passes from the dural venous sinus, pierces the pericranium and cranium, and the mostly major part of the emissary veins present in this region, because it is a thick layer, no? So if it is thick layer, so it contains the major portion of the emissary vein. Thick layer contain emissary veins. Hmm. So first, it is also called dangerous layer. Dangerous layer of scalp. Why? Because we have drawn the diagram. Let's say this is the epineurosal layer. Below this, we know the fatty layer. This is called loose areolar tissue present. There is a loose areolar tissue present here. This is called loose areolar tissue layer. And emissary veins present here also. These are emissary veins connect below to the dural venous sinus. This is the venous sinus. Hmm. So if there is any infection or any bacteria present in the loose areolar tissue, it can go from the emissary vein to the deep to the brain. So this is called dangerous layer. We can write here, any infection or foreign particle from here can travel deep, travel deep to brain through emissary veins. emissary veins. Emissary veins के through this infection from the above can go to the deep because most of the emissary vein portion present here. Done. So this is clinical point. Hmm. This clinical point. The next clinical point is the first, and the second point is black eye formation. How black eye formation basically we have seen in the movies when someone punches near to eye, so there is a black eye formation. Eyes become complete black. So these are called black eye. So how it forms? So again we go to the this diagram. So there is, let's say there is any injury in the head. So so there is a rupture of emissary veins because it is present in the loose areolar tissue. So rupturing of emissary veins lead to the bleeding. So this blood from the emissary veins travel deep. Now here we know the aponeurotic layer is open. It is not connected to the scalp. It's connected to the skull. So this blood travel deep and collected near the eye region. This is blood. It travel near to the eye region. So there is black eye formation occur here. And right, any injury in scalp होगा क्या उससे? Bleeding. Which vein? Emissary veins. Bleeding. So blood travel down to eye, and the reason is open because aponeurotic layer is not attached to the skull region. It is attached to the skin, so it is open in front. Due to open aponeurosis, aponeurosis layer. So that's why this open aponeurosis is demarcated. Hmm. So there is black eye formation here due to this region. So this layer is called dangerous layer, and there is important another thing. This layer also is safety layer for skull. So this mechanism called safety valve mechanism. This is also safety layer for safety layer of skull. Another point. Loose areolar tissue also has safety mechanism called safety valve mechanism. Safety valve mechanism. So what happened? Let's say again there is again hard injury occur. So even this hard even break the pericranium. So there is bleeding occur in dural venous sinus. Very hard injury occur and it even break the pericranium. the pericranium and cranium bone. So there is a bleeding occur in dural venous sinus. This dural venous sinus bleeding, if this emissary vein is not present, can compress the brain. There is a pressure buildup inside the cranium and compresses the brain. So this can be the fatal. But due to this emissary veins present in the loose areolar tissue, this blood pressure can be managed because this blood transfer to the outside superficially. So there is a pressure maintenance occur due to this layer. So this is also safety mechanism for to prevent injury, any injury. So due to due to injury, the bleeding occur in venous sinuses, venous sinuses. What happens? It compresses the brain. The brain, but due to emissary veins. Remember, emissary veins are very less, so this can travel blood from outside to inside and inside to outside in both directions. So this helps in maintaining the pressure in both directions. Emissary vein. Here there is pressure buildup. Pressure buildup. Hmm. There is emissary veins. Due to emissary veins, blood go superficially and maintain superficially and maintain pressure. So what happened? Brain is spared. Brain बच जाएगा. So brain is safe. Brain is safe. So this layer is dangerous and also helpful. Both things are included depending on situation. Then, hmm, so the next layer is last layer is pericranium. Fifth is last, the pericranium. pericranium. So it is the covering of the bone, covering of the bones, just above and below. It is present in continuous fashion. Above it is called pericranium, and inside the bone it is called endocrinium. Hmm? Let's say this is the bone, this is one bone, this is another bone. So this layer present like this. Inside it is continuous as endocrinium. This is pericranium, and this is endocrinium. These are the bones, bone, bone, and these are the sutures. Basically, these are sutures. Hmm. So this is the pericranium which cover the skull, basically cover the skull bones. Done. So clinical point about is this layer is cephalohematoma. Cephalohematoma. What happen is, again there is a bleeding occur. Due to bleeding, all these are related to injury in the head. There is bleeding occur. Oh, and even blood collect in this region. Blood collect in this region, bone and the pericranium layer, facial layer, like this. This is bone. This is layer. Hmm, and the blood connect between this region, like this. So what happens? This blood take the shape like the bone. Blood collect between bone and pericranium layer, cranium, and form shape and gain shape like bone. Bone जैसी shape ले लेगा ये. So this is called cephalohematoma. It is also due to injury. This is blood. Done. So this is cephalohematoma. So these are the layers of the scalp. All 5 layers of scalp, basically superficial to deep, and their clinical points: sebaceous cyst, dangerous layer of scalp, safety valve mechanism, all these things. Aponeurosis, aponeurotical incision point, how we give incision, cephalohematoma, black eye, bleeding occur in the connective tissue region. So these are the layers of the scalp. Done. Next point. So now we are covering the some marking of the skull bone. So this is the skull bone. Done. So remember there are some margins. Remember this is the this eminence. It looks this is the bump like eminence. This is called frontal eminence. Hmm. The next is there is an arch form here, arch like fashion. This is called superciliary hilary arch. This point is where we took bindi, where we put bindi. This is called glabella. Then next is there is a common point between the this is the nasal. Remember this is the nasal bones and there is a frontal bone. There is a point. This point here. These three bones attached. This point is called nasion. After this is called anterior nasal spine. These are some points. This is this notch. This is called superior orbital notch. This is notch or foramen. Sometimes it is maybe foramen also. Foramen also form maybe or notch or foramen. This is again if this is superior, so this is called inferior. Mm. This is inferior orbital, but this is foramen. Then this point where the two mandibular bones join completely. This is called symphysis menti. Symphysis menti. And there is an opening present here. This is called mental foramen. From mental nerve and vessels passes. mental foramen. Done. Now this is the orbit, and here is there are many margins. The frontal margin is the roof margin, roof superior margin, lateral margin, medial margin, and the inferior margin. So they are the bones contribute to the formation of the orbital margins. These are the nasal bones, whole are laser, and now the margins of the orbit, margins of orbit. So the margins of the orbit are, first is superior. It is contributed by frontal bone. This is the frontal bone, na completely. This is the completely frontal bone. This is maxilla bone. This is the point where the two maxilla connected, suture. This is zygomatic bone. This frontal bone. This is lacrimal bones. Sorry, nasal bones. Frontal bone and lateral wall, lateral margin. Lateral is contributed by, this is the lateral margin. So there is a process is present. This is the frontal bone, and it go towards the zygomatic bone. So this is called the zygomatic process of frontal bone, and this zygomatic bone, it go towards the frontal bone. So this is called the frontal process of zygomatic bone. These are the parts which go towards the other bone. So these are called processes of other bone. This is the frontal process of zygomatic bone. This is called the zygomatic process of frontal bone. We include here frontal process of zygomatic and zygomatic process of frontal. Next is lateral medial margin. Medially, there is a frontal bone, basically maxillary process of frontal bone, and this margin continue this frontal bone, and this go inside. So this is called the lacrimal. This is lacrimal bone. This is lacrimal bone, not lacrimal bone. So this is lacrimal bone. So medial margins contribute by lacrimal bone. Frontal process of maxilla. Oh, maxillary process of frontal bone. Maxillary process of frontal bone and crest of lacrimal bone. This is the lacrimal bone crest only, and crest of lacrimal bone, and the inferior is, the last is inferior. So inferior is contributed by the maxillary bone and the some part of the zygomatic bone. Maxilla and zygomatic bone. So these form the margins. Done. Next, come to the blood supply of the scalp. Blood supply. So blood supply of scalp like this, we draw the scalp from the superior view. So there is a superior view of the scalp. This is the superior view. Let's say this is the anterior nose and here is ears. Done. So this is the superior view. Now we draw the nerves. So the first nerve is like this. One, two, three. Wait. We draw the blood supply, no? We draw blood supply only, remember. First we draw blood supply, then we draw the nerve supply. This is the blood supply. So we draw the arteries. So first artery, second artery, then there is third artery, then fourth, and the last fifth. So there is a four arteries in one sided. This is the one side arteries. Similar arteries present in this side also. This is the arteries of the one side. So first we name it. These are, this is, wait, named separately. This is superior trochlear artery, trochlear artery. This is superior orbital artery, orbital artery. This is superficial temporal artery, superficial temporal artery. This is posterior auricular artery. Posterior, this is the behind ear, na? So this is called posterior auricular. Auricular artery, and this is occipital artery. Occipital artery. Done. So first, these are branches of ophthalmic artery. Ophthalmic artery. And this ophthalmic artery is branch of internal carotid. This above. This is internal carotid artery. Internal carotid artery. The superficial temporal and posterior auricular, these are branches of external carotid. External carotid. artery. And this is again branch of external carotid also. This is also external carotid branch. Done. These are the branches. Now come to the venous supply is also similar. Venous supplies from the dural venous sinuses, and some veins also include. Similar venous pattern include superficial temporal occipital vein, superior superior trochlear and orbital vein. All venous pattern is similar. We write venous supply is same. We write only veins direct, superior trochlear and orbital. Superior orbital. So here is superior orbital vein. Then superficial temporal vein, posterior occipital vein, occipital vein. So these are the veins of the venous supply. We write here. Then, so this is the venous supply of the scalp. Now come to the nerve supply. Nerve supply. So again, we draw a scalp. Remember, this is the superior view. This is also superior view. We draw only superior view. So again, next, this is skull, this nose and ear. These are the ears, let's say. This is superior view. Now we draw the nerves. So remember, there are four nerves front of ear, four nerves behind the ear. First nerve is like this. This is the first nerve, second nerve, third nerve, and the fourth nerve, fifth, sixth, seventh, and the eighth. So these are the nerves of the one side. Remember, this nervous similar pattern is present in this side also. So this is the half portion. So now we name it. So this is superior, similar like artery pattern, trochlear nerve, similar artery pattern, trochlear nerve. This is superior orbital nerve, orbital nerve. This is this is zygomatically-temporal nerve. This is auriculo-temporal, zygomatic and auriculotemporal nerve. Now these are the different nerves. So first, this is the great auricular nerve. Auricular nerve. This is great. This is lesser auricular nerve. This is greater auricular nerve. Remember, these great and greater are different. Greater auricular nerve. Auricular nerve. This is third auricular nerve. We call it third auricular nerve. Auricular nerve. These are the cervical branches, cervical nerves, and these are the trigeminal. Basically, these are the branches of the trigeminal nerve. So we named it. These are first branch of trigeminal nerve. First branch is ophthalmic. We write ophthalmic. Similar artery pattern, ophthalmic nerve and ophthalmic artery. First branch of maxillary nerve, first branch of trigeminal nerve is called ophthalmic nerve. These are second branch, second trigeminal nerve, geminal nerve, and these are cervical branches. So they have particular root values. These have C2, C3. This has C2. This also has C2, and this has C3. Basically, these are the nerves. And C2 and C3. These are the ventral branches. These two are the ventral branches. Ventral branch, and these two are the dorsal branch of the cervical nerves. These are cervical branches. Done. So this is the nerve supply of the scalp. This is nerve supply of the scalp. This is the blood supply, whole, and all these skull margins and all the scalp layers. So this is the some important portion of the scalp. We have drawn this. So now next time we cover the another point. Thank you.